platform. We have a faculty with us, Dr. Khalid Hassan. He works in Florida Hospital. And then we have Dr. Saad Niaz. He's co-director. He works in Karachi, and I work in Lahore. So, and Dr. Nadeem Tihami from UK is also going to join soon. So up till now, we've covered about 44, 46 topics, and there are a few more left. And one of them was ampullary adenoma, and you have been kind to agree to deal with this topic.
Excellent. Well, thank you very much. It's an interesting topic, and and people have been concentrating much in EUS, CRCP stuff a lot. The fashion is trending sometimes towards some subjects, but I
Yeah,
think this is very important subject as very much cases that you can see of these, and people a little bit are shying away sometimes of doing those amphilectomy stuff. So I think it's a very good topic. Thank you very much, and I'll be happy to participate at any subject that you want in the future, inshallah.
very good. Dr. Said, can we go on live now?
Yes, sir, we can. We are live now, sir.
Should I start?
Yes, sir, we can start, sir.
Dear colleagues, thank you very much for joining back on weekly USCRCP webinar series. I understand this is Ramadan and most of you are fasting. You're busy in your Ramadan routine, but still you have been able to spare time to join us. And this time we have requested Dr. Abdurrahman Al-Fada from uh, King Faisal Specialist Hospital and Al Dara Hospital in Saudi Arabia. He's a consultant in advanced endoscopy, and he's director in advanced therapeutic endoscopy in King Faisal Specialist Hospital. He's been very kind, and he's going to speak on ampullary adenoma and ampulectomy. I'm sure this is a topic which you'll love to listen. And Abdul Rahman Al Fada is a very, very experienced person. We've been seeing his videos on Boston Scientific Forum and other Middle East forums, and his performance in those cases have been brilliant. Dr. Abdurrahman, all yours.
Well, thank you very much, Dr. Guys, for this great introduction. It's always an honor and pleasure to join the ERCP and EUS webinar. This webinar have been really very active, and a lot of titles, interesting titles, and very excellent update have been going through this webinar. So it's a pleasure to be here and to share a lecture about ampullary adenoma and ampulectomy. As you know, ampullary adenomas are not very common lesions that we usually face in our clinical practice. To be honest, we see lots of chronic polyps, gastric polyps, and maybe others, but ampullary adenoma, you probably can see it every while and then. It's not really that much common. The prevalence have been increased, as we all know, by two main modalities, because we have more endoscopic procedures that have been done these days, so incidental finding of adenoma can be seen, and as well as cross-sectional imaging have been increased, so ampullary adenoma and other types of carcinomas have been increasing. Um, Usually, these adenomas, as we know, are asymptomatic and they can be found, as I said, incidentally. And sometimes you can find some patients with symptoms that I'm gonna explain in the next slides. So if we talk about ampullary neoplasms, we are talking not only actually about adenoma or adenocarcinoma. Going into the literature, we can see that there are many types of ampullary lesion, including adenocarcinoma, adenosquamous carcinoma, and the rare adenoendocrine carcinoma, and small cell carcinoma, and lately the undifferentiated carcinoma. So it's very important after resecting this specimen to sit with your pathologist and probably to tell him that this is an ampullary lesion that we want to look into, and you may be surprised that you can find one of these rare lesions that are presenting in the ampullary mass that you have seen or you have resected during endoscopy. So as we know, almost all, more than 95 of lesions when we see in clinical practice are based on the first two types, which is adenoma and adenocarcinoma, and the other four kinds of carcinomas or malignancies comprised of 5% of the rest of the malignancies. The progression, if we look into the adenomas of the duodenum, they are very similar to the progression of colorectal cancer rate, but there is no very strong evidence that can look into the progression of this cancer due to the less experience and low numbers of adenomas in patients' presentation. As you know, adenomas can be sporadic or can be in context with other familial polyposis syndrome. And as we know, around 85 or 80% of FAP patients will develop duodenal adenoma, and the lifetime incidence of developing adenoma of the periampullary area can reach up to 100%. So it can be one of these two kinds. What about the presentation? As I mentioned, most of the patient can be asymptomatic, that can be seen incidentally, but there are some features that can probably help into looking into the possibility of an ampullary lesion to be evaluated and dissected either endoscopically or surgically. So these include nausea, vomiting. Patient can present with biliary colic and weight loss sometimes. One of the important symptoms is painless jaundice in around half of patients or more. Cholangitis is not very common presentation, but if there is a big mass, it can present with cholangitis. And interestingly, though, the adenoma or the adenoma lesion can compress the pancreas, though acute pancreatitis is not quoted as a common symptom in those patients who presented with ampullary lesions. It's very important to accurately diagnose and stage the adenomatous lesion or the ampullary lesion for two main reasons. The first is that you can decide the best modality of treatment, whether you are going to go endoscopically or whether you're going to send this patient to surgery, and to establish the prognosis and probably the surveillance as well. We have modalities that I'm going to go through. The best and the most common one is endoscopy, upper GI endoscopy. I'll talk about ERCP, EUS rule in detecting and staging adenocarcinoma, as well as MRI, MRCP as well. So endoscopy, the best scope that can be used, as we know, is the duodenoscope. This is the one that we use usually. It gives you good visualization of the area, and it allows you to take good biopsies as well from the site. Using the elevator functionality as well can help you getting different parts from different site or from any suspicious malignant lesion. Now, if you look into any ampullary lesion, probably we can tell if it's benign or if it's malignant histologically without taking biopsies, but it's of course a necessity to have a biopsy to confirm the presence of ampullary adenoma or adenocarcinoma in the ampullary area. In general, benign lesions are usually having regular margin. They have no ulceration and they don't spontaneously bleed. Looks like a polyp actually in the ampulla of Vater. And when you do a test of the how soft is the lesion, usually this lesion will be soft and it's not hard, indicating that it's a benign ampullary lesion rather than a malignant one. Now, what about the biopsies? How good are the biopsies having the diagnosis and detecting the diagnosis? It's actually good for benign ampullary adenoma, more than 90%. But unfortunately, for adenocarcinoma, it's less, and the missing rate of this can be around 30%. So we are talking about around 70% of detection rate in those lesions. And that's because some foci of malignancy can hide distally, and the biopsy forceps is just taking the proximal part, or it's taking the benign part of the lesion while the malignant part is not there. So it's very important to prevent this is to take at least 6 to 8 biopsies from different sides of the papilla, and it's very useful to use other visualization techniques such as FICE and MBI to look into the surface of the lesion, the vascularity, and the platform pattern. And it's as well helpful to take the biopsy before or after or several days after sphincterotomy so that you will hinder any effect of the thermal ablation. So we discourage usually taking biopsies just after the sphincterotomy when it's done. If it's done before, and then if you are going to do a surveillance, for example, after, you have to take the biopsies after sphincterotomy in several days. What about ERCP? We all know that ERCP plays a major role in staging and management of obstructive jaundice that can be a complication of ampullary adenoma. The ingrowth of the adenoma into the pancreatic duct, into the CP duct, does not always indicate malignancy. We still can have a benign invasion, but then we have to think if we are going to remove it ourselves or we are going to probably ask the help of a surgeon to do a Whipple procedure or hepatogeneostomy or other procedures to help looking into how can he resect this lesion. There is no doubt that endoscopic resection for ampulectomy have been increasing, and it's safe and it's effective, but it's always important to look into the lesion itself, its extension, and what is the best for the patient prognosis and to plan it from there. ERCP, as we know, permits evaluation of the intraductal extension in conjunction with EUS. It's we can place a PD to reduce the risk of pancreatitis, and if required, we can deploy a CBD stent as well for palliation and prevention, probably of obstructive jaundice. I personally always put a pancreatic duct stent of 5 French, and the CBD actually I most of the time I don't do, and I sometimes I do put if the patient bilirubin is high or if there is a suspicion of stenosis in this case, or I just want to the patient to get his bilirubin down to prevent cholangitis. But PD, I think it's an important to prevent the risk of post-ERCP pancreatitis. MRI and CT scan, they are useful actually for diagnosis the lesion, but they have a very limited role in T staging. It has a poor rule actually detecting nodal staging, and it has a modest or low metastatic evaluation value. So it's good for diagnosis, but probably it won't give you further information about the lesion extension, the lymph nodes, and the metastasis as well. Endoscopic ultrasound allows assessment, as we know, for the area, the periampullary wall layers, infiltration, and pancreaticobiliary ducts. There is no, if you look into the literature, go through the literature, you will not find a clear consensus about the role of endoscopic ultrasound prior to patients treated for ampullary lesions. And if you discuss it with different experts, you will have more than one opinion. And as you can see, some experts will not require EUS prior to ampullary endoscopic ampulectomy, I mean, especially if the ampullary adenoma is less than 1 centimeter in the diameter and there is no signs of or even symptoms that suggest malignancy. Others will still probably ask for EUS prior to endoscopic intervention or surgical intervention. So it's usually not a black and white decision. Depends on the expertise of the EUS people in your specialty or in your hospital. Depends on if they did really have an interest to do such cases, look into the layers, different layers, and it depends on the availability of the endoscopist or the surgeons as well. Now, this is the largest meta-analysis that have been done looking into the staging accuracy of ampullary tumor by EUS. And as you can see, for T1 lesions, we can see that we have a around 74 And for T4 lesions, it reaches up to 84. So we are talking about 70s to 80s, and the same of 70s in the sensitivity. So it's a good modality, yet it's not the best modality to diagnose the extension of the ampullary tumors or lesions in the ampullary area. If you look into the nodal status by EUS diagnosis, it carries a modest sensitivity and specificity ranging between 70 and 74%. So it can be used as an adjunct way to look into the staging of the ampullary tumor of the ampulla itself. So to cut it short and to look probably into the easy way to do it, I think if there is a clinical suspicion of invasive cancer by symptoms or sign, and the region, appears amenable to endoscopic resection by endoscopic features, then EUS probably might not be required, and the endoscopist may need to resect these lesions without an assessment without looking into endoscopic evaluation. So what about the limitations of EUS? As we know, EUS is operating dependent. You can have different staging opinions from different endoscopists or endosonographers or endoscopic sonographers. So it's an operator dependent. And the other problem is that really for ampullary adenoma, they can be overstaged if there is a peritumoral inflammatory changes around the area, while it's not really a part of the mass of the tumor, and it can be understaged if there is a focal pancreatic infiltration. So these are probably the main two disadvantages. So how about intraductal ultrasound? Is there any role of intraductal ultrasound, and there is any value of it? So if we look into it, intraductal ultrasound are better, but it's not excellent modalities. It's comparable. Looking into the evidence of intraductal ultrasound, we can see that the accuracy is ranging in the 80s and 90s in the best hands, while for EUS it's between 70s and low 80s, 67 to 77 actually. The problem again of the intraductal ultrasound that it has a limited availability. Not everybody is interested in doing it. It needs a good training, good cases to look into. It can be technically more invasive, and it's not a very cheap procedure. And for those patients who have to pay for such procedure, they might really pay a good bunch of amount. Though it can be inappropriate in deciding which patient to go for endoscopic ampulectomy or for surgical one. Now we'll talk about endoscopic ampulectomy. It must be done by really endoscopists who have training and enough training into doing this. The goal for any ampulectomy is to do an in-block total resection and removal of the neoplasm if possible, as it increases the likelihood of complete removal when you do it an in-block. It provides clear margins for our pathologists for histological evaluation. It can reduce the procedure time rather than piecemeal resection as well. However, this is not always happening. Some adenomas are large in size, so you can't remove it and in block, and it can have a bad location or difficult location, which will hinder and limit endoscopic accessibility. And we have sometimes to use APC or adjuvant ablative therapy that can increase the procedure time. So if we look into the steps of ampulectomy, first of all is submucosal lifting, then endoscopic resection, then retrieval of the resected specimen, then ablation if needed of the residual tumor, then sphincterotomy and stent placement at the end. We'll go through each step and we'll show a case or two about this. For submucosal lifting, it's not a must. It as a controversial. I personally don't do it, and I do it in probably few cases. We've done in our center around 22 or 23 ampulectomy. I have been doing from this around 12 or 13. So I used once or twice lifting. I don't do it much. It may increase, as you know, the risk of technical success and decreases complication, similar to other lesions that can be removed by ESD or big polyps or musectomy. And sometimes saline can be injected with epinephrine and methylene blue to minimize bleeding and probably to enhance endoscopic visualization of lesion margins. However, submucosal saline has its own disadvantages as well. So you may lift the lesion too much, creating a dome that can cause difficulty in placement of the snare for effective in-block resection. And it might be non-raisable lesion. So if it invades and if it's malignant, may not lift due to the tethering effect of the biliary and the pancreatic duct. And then post-resection lifting with pancreatitis 6 has been reported in some of the literature for no clear reason. So there are advantages and disadvantages. I think the take on this is that if you are more comfortable doing it with evaluation, then you do it. If you are not, you don't. I train in an era or in a time where they don't do elevation of the ampulectomy for endoscopic ampulectomy. So I continued that. But if you think that it's indicated for a reason other, then you can just inflate either saline or even other materials that have been coming in the market recently. Up to date, if you look into the evidence, there is no, the evidence supports submucosal injection uh, before ampulectomy. There is nothing about this, and possible indication may be adenoma with lateral pleural spreading tumor. So if you have an adenoma with a lateral spreading tumor, then you may want to inject the whole area submucosally using saline or any viscous solution, and then removing the adenoma and remove the adjacent malignancy or tumor that is going around the ampulla itself. So about endoscopic resection. Uh, Regarding the snare, there is no snares that are preferable. I think it's a personal preference. For me, I like to use the hexagonal monofilament snare, but then you can use the 3 centimeter standard braided oval or hexagonal snare as recommended. Maybe if the tissue is soft enough, then you can use the braided one. If it's really hard and you want to have good radial force in the duodenal wall, then you use the monofilament snare. Thin wine snare have been claimed that it's having less complication due to limiting the dispersion of the energy into the duodenal wall, and that will limit the risk of energy to the pancreatic orifice as well. But that needs to be further evaluated and investigated. And then, as any polypectomy, peripheral circumferential incision of the adenoma with needle life may make it easier, I mean, for any SD lesion. If you are familiar using needle knife in the duodenal, then you may want to go through the lesion and create a circumferential incision, then just put your snare like a hybrid ESD, if that's a way that you feel comfortable with. And as we know, the snare is just placed at the tip of the adenoma. We have to close it to the maximum. Then we have to check the mobility in the duodenal wall. Then after that, we just do the endoscopic ampulectomy and retrieve the sample. And it's important to do suctioning, not to have distal migration. I will talk in few minutes. So what is the optimal current if you are looking into resecting ampullary adenoma? Um, no clear general recommendation regarding this matter. It's again an expert preference. Some recommended pure current, cutting current to preclude edema originated by the coagulation mode, although bleeding risk, as we know, can increase. And most of the experts recommended blended electrosurgical current and alternating cut coagulation modes. The power, you can start by 30 watts and then go up to 150. I found it very useful to do 50 to 60 watt in those ampullary lesions, and we don't remember increasing it except in one or two cases when we have a very large or a large, it was a 3 centimeter one with a hard component, then the watt have to be increased to minimize the risk of energy or cutting delivery, and to have the resected part resected in a reasonable time. So we use Endocut I, Effect 2, using the herb machine for our practice. And then it's very important to retrieve the specimen early, and not to look into the site and start treating the residual part, because it can easily migrate to the duodenum distally, and then you have difficulties into retrieving it, and you may lose it, not allowing the opportunity of you and the pathologist to look into the pathology and deciding the prognosis and the surveillance. Sometimes you can do antiperistaltic agents, and it's wise to use it if you want. And you have to use suctioning to avoid intestinal migration, as I said. And then usually we resect, we take the biopsy, we retrieve it with the scope. Then after that, we reinsert our scope to look into the lesion and to treat it. And it's not advisable to aspirate through the accessory channel, as you can cause fragmentation of the sample, and you want it to be as much as I can as you can one sample if it's in block. So it's advisable to take a Rothnate or something and to retrieve it, taking it outside totally with the scope, and then reinserting the scope again. Then you can, of course, put it in a block and to look into the margins by your pathologist as well. Now, about residual tissue, usually, as you know, we use adjunct therapy to residual adenoma after M block or piecemeal resection of the ampullary lesion, looking into active bleeding, bleeding stigmata that can be prevented, or residual tissue that needs to be ablated. And the benefit of adjuvant therapy, interestingly, is controversial. And again, I think it's an effective therapy, but due to probable limitation of data compared to other modalities, we don't have a very good solid evidence into the benefit, but it's recommended, of course, to be used into the margins of the resected part. And it's quoted that with ampullary adenoma, the overall success rate is around 80%, and without it is uh, 78%. So it's very comparable. We use APC, and sometimes use the tip of the snare, depend on the case itself. Um, we sometimes do biliary sphincterotomy, as I said, and it's always we do a pancreatic duct. What about sphincterotomy and stent placement? The aim of this is to enhance the technical success of the procedure and to decrease the complication of endoscopic ampulectomy. Though sphincterotomy has its drawbacks, as if you use it sometime, you can have difficulties using an in-block resection due to the opening that you made with the sphincterotome itself. It can hinder histological evaluation of resected specimen because of the trauma and the injury that you created with the sphincterotome. And as any sphincterotomy, it might increase bleeding, perforation, and most important is possibly it can cause a tumor seeding as well. So to look into the orifices after resection, you can insert methylene blue before through the PD, then do the endoscopic ampulectomy. Then after that, you will see the methylene blue is coming through the pancreatic duct, and that can help you finding the opening, then cannulating the pancreatic duct itself, and finishing the procedure. You can use secretin as well to look into the secretion of the pancreatic juice. and you have to place a pancreatic stent. 5 French is good enough, uh, preferably a single pigtail to prevent proximal migration of the stent into the pancreas. Though if you are happy with regular stent with flanks, then you can just place it. And interestingly, acute cholangitis after papillectomy, as far as we know, is uncommon, and probably prophylactic biliary stent placement or biliary sphincterotomy is unnecessary, but it can be done to minimize the risk as well. So this is a 52 years old male who was found in a CT scan to found a mass. He presented actually with right upper quadrant pale, suspecting acute cholecystitis. Um, Endoscopy have been done, ERCP have been done. As you see, we are using the snare here just to lift up and down the lesion itself. This is not a big lesion with clear demarcation of the margins. We didn't have probably to use much of alternative modalities. And then we go all over with the snare, and then going centralizing or taking the mass into the lumen to prevent injury. Then this is immediately after the procedure, taking the specimen, retrieving it, sending this histology specimen to our pathologist to look into it. And this is the result. You can see that in this case, we have good margins. We did not inject methylene blue in this case. So we are trying to look into the PD now, going into the PD. And fortunately, the PD was in this case not that difficult. Cholangiogram have been done. We are doing pancreatic sphincterotomy to prevent stenosis, mainly post ampulectomy, and then a single pigtail stent have been inserted as well to look into this area. Okay, so if we look into the endoscopic outcome of endoscopic ampulectomy, we can tell that the success rates vary in the literature. The best center, they've been quoted it at above 90%. Others have been quoted a failure of one in each two, so around 45 to 50%. And the recurrence rate as well is very variable. So probably we need a more and a bigger and hopefully a prospective trial to look into this, as the recurrence rate have been quoted between 0% and around 33%. One in each three of patients can have a recurrence. But we know that intraductal adenocarcinoma growth has less favorable outcome compared with adenoma with no intraductal growth. But there are predictors for success, and if you are willing to do it, or you are aiming to increase your practice during endoscopic ampulectomy, they're probably for males for lesions less than 2.4, and then other two factors of an age of around 48 and above, and lack of genetic predisposition of adenoma. So these are predictor of success and probably less recurrence maybe than other adenomas that can recur. Complications, as any endoscopic complication, bleeding and pancreatitis have been reported. Papillary stenosis is not that common, but it can happen. Interestingly, perforation is not quoted very high in the literature, between 0 and 4%, and less is the cholangitis. That's why probably we don't put a CBD stent on those patients, except if they have a pending cholangitis or a very high bilirubin with mild leukocytosis. Then it's wise to put it and remove it maybe after 2 weeks only, after you go and inspect for removal of the pancreatic stent as well. Mortality have been quoted 3 in every 1,000 cases, or around 0.3%. What about surveillance? If you resect an ampullary adenoma or adenocarcinoma, what you have to do? So usually the surveillance is based on the histology of the specimen itself and the margins of the resected lesion. That's why we advise always for an in-block resection of these lesions. If there is a history of FAB, the risk of recurrence is higher, so probably more aggressive surveillance is needed. Then you have to look into the patient as a whole, looking into the patient age, the comorbidities that the patient have. There is no clear consensus in this. On this is one of the literature that had reviewed it, and they look into if into they do the polypectomy, I mean the ampulectomy, then they come after 3 months. If there is no residual polyp after the primary resection, they do endoscopy after 3 months. I mean, then if the biopsies come negative and there is no residual adenoma, they will do it after a year. So once 3 months, then once after a year, then every 3 to 5 years, which looks into colonoscopy surveillance for chronic polyps, some of the chronic polyps. But if the patient is having FAB, then probably keeping it every 3 years is wise to look into an early disease recurrence and treating it before progression and metastasis. So, to summarize and to conclude, as we know, EUS and ERCP have influenced the management to patients with ampullary adenoma with no doubt, and we can see more cases have been done now for ampullary adenoma. Endoscopic ampulectomy had replaced in a very good portion the surgical intervention for ampullary adenoma without a ductal extension. Endoscopic ampulectomy has a lower morbidity and mortality based on the literature than surgical approaches. And as we know, ampulectomy is effective and safe in the treatment of ampullary adenoma in experienced endoscopists, but as it has its own complications as well. Though the limitation of endoscopic ampulectomy include the technique itself, it might be difficult, especially if the lesion is not clear, if the margins are not very visible, if the lesion is large, and the experienced endoscopists on this are not much in the field. That might limit endoscopic ampulectomy in many cases. The other problem is that it has a moderate recurrence rate of around 30%, and the need for post-procedure endoscopic surveillance is there. So after resection, you have to look into the surveillance as well. So the best technique for endoscopic ampulectomy is subject to the adenoma size, as we know. In block resection is always recommended, but if you do a good piecemeal resection fashion, then that's fine as well. Though, as we know, the pathologist always prefers to see it once in a block pin to look into that, into the pathology, and can tell you if the tumor is completely resected or no. And then long-term follow-up information is required to clarify the appropriate surveillance interval for patients with sporadic adenocarcinoma. By this, I thank everybody for being here, and I'll be happy to take any questions.
Thank you, Dr. Alfada. It was a wonderful practical session, full of information and your personal experience. There are lots and lots of questions. Few have been posted in question and answer session. Uh, Dr. Ilyas Khan has asked, periimpullary lesions are managed on line of pancreatic line or small intestine from oncology point of view. What do you think?
Sorry, I
Should
can't
we
hear you, Dr. Yas. Can you repeat, please?
Periimpullary lesions are managed on which line? Are they managed on the line of pancreatic tumors, or are they managed on the lines of small intestinal tumors from the oncological point of view?
No, it's managed in our unit actually. Our practice is that we don't prefer EUS for those lesions except if there is a real suspicion by MRCP that there is an invasion. As you know, it's very operator dependent. You can't tell 100%. Then we perform the ampulectomy. Then after that, we do the thermal ablation. We have a multidisciplinary team approach, so oncologists will be with us to talk about it and to see if they want really to ask for any kind of oncological therapy or no.
And do you do biliary and pancreatic sphincterotomies before?
Well, a very good question, Dr. Guest. Usually what we do is pancreatic sphincterotomy. Biliary sphincterotomy, we don't do it oftenly.
Hmm.
We do insert a common bile duct stent on those patients, but we do not always perform a biliary sphincterotomy. We do pancreatic one just to prevent the risk of pancreatitis and to be amenable for to have less incidence of stenosis as well. But it's
And
always
Dr.
right, of
Alfa,
course, to do a CBD.
under
Yes.
what situations will you straight away say no to the endoscopic ampulectomy? You've seen certain things, one, two, three, four, after which you'll say that no, this is not the case for endoscopic ampulectomy. What are the clear-cut
Yes.
signs?
Well, the first of all is the patient himself, Dr. Gaze. If he is, if he's elderly, if he has multiple comorbidities, if the patient is complaining of bleeding dialysis or having or high INR or platelets, if we think that the life expectancy for this patient is not high, so this is patient-related factors that we look into usually before doing this. If there is a clear invasion that can be seen by imaging, by MRCP or endoscopic ultrasound into the pancreatic duct or into the common bile duct, so we refer those patients for the hepatobiliary surgeon to do surgery for them. These are the things. We have probably very large, one or two cases of large lesions of around four and above. So after discussing, we did not prefer to do it ourselves. We discussed with the patient as well, and we have an agreement that this patient is probably to be done by the surgery. So I'd say if the patient is fit, if there is no evidence of invasion into the common bile duct or the pancreatic duct, if you have done cases that can let you do this case with no problem, then you go and do it endoscopically. Otherwise, you can refer them to the surgeon.
Uh, do you do pancreatic stenting before doing the ampulectomy or after? Or do you prefer doing piecemeal or you prefer doing en bloc resection?
Yes, for lesions, Dr. Grace, which is less, which can be taken by the snare easily, and we're comfortable enough that we are not deep or not superficial to keep a remnant tissue, we do an in block resection. Um, for lesions that are we are not sure about it, we do it probably in two or three pieces actually, and we don't do an in block resection. This is for the type of the resection itself. For pancreatic duct, what I prefer and what I learned is that I usually cannulate the PD, infuse methylene blue, then do the ampulectomy. Then after ampulectomy, I go and I put a PD stent. But I do not use secretin. I do not place a pancreatic stent before. And we do the methylene. And as you know, usually with methylene blue, when you do it, you will really see it. Sometimes you can have a bluish like everywhere, but if you flush the area, then you can see really the site of the methylene blue coming. So that's what we do usually.
Dr. Abdurrahman, if I've heard correct, you don't prefer injecting submucosely before doing the ampulectomy. Is that right?
Yes, I'm not يعني sure if this is the right thing or no, because if you look into the literature, there is nothing much really that look into this in depth, and it's a
Hmm.
preference. I don't do it personally because, as I said, it might cause if you are not careful, it might make it more difficult to remove. Then the other thing, because I'm using methylene blue into the PD itself, maybe if we inject some mucosal saline with methylene blue just to detect the depth of the lesion, it might make the field not very clear actually. So we just make it carefully. We take our time looking into our snare, opening it, closing it, keeping it just below the lesion itself, and then doing it without do submucosal injection. As you know, submucosal injection have been very beneficial for many lesions, and the orais, for example, and the viscous have been tried as well now. And I wonder if there is anybody had looked into this because it might be really a good solution to use. If you want really to take your time to do a good one or to do the piecemeal, then maybe using any viscous solution can help before you perform the ampulectomy itself.
We have the other experts. So Khalid is here, John Leeds is
Riyaz,
here,
can I ask a question, please?
Saad is here. Yes, please, Saad,
Hello,
you
Dr.
go.
Khalid, how are you?
Yeah. Okay.
Nice to meet
Dr.
you.
Alfada, excellent talk. This is Saad Niaz from Karachi, Pakistan. What is, there was some discussion about post-ampulectomy bleeding and what time does the bleeding occur? And there was some suggestion that one should go. I was watching
Sadhbhai, we lost you. We can't hear you.
We cannot hear you.
Yes, we can. Gyasbhai, can you hear him?
Yeah, no, we cannot hear him.
To
I
go
think
after a few and back and
Saad,
look.
Sadhbhai,
Some people go later.
we can't hear you.
Yeah, Dr. Saad, I catch some of the question, and I think the question was about the bleeding. Yeah, I'll answer this question. I mean, the bleeding have been quoted variable in the literature, but for any ampulectomy, as you know, you can expect bleeding. And especially if you want to remove this part from the small intestine, it's not just like any polyp that you would remove. So you expect a bleeding or a gush of blood that comes after this. Um, for us, we don't clip after, or we don't even stitch it with clip. I mean, we don't approximate it, we keep it, as you know. We do APP and the thickness here as well if we are looking into the stigmata of bleeding. If it's a bleed, then we manage it like any other bleed by epinephrine and clipping and watching, observing the patient, keeping him probably in the hospital for 24 hours, looking into the drop in the hemoglobin and others. But definitely bleeding is one of the side effects that we always have to be careful about it in ampulectomy actually. Um, I did 2 or 3 cases with um, gels that can prevent, like post-ESD gels. But was came to us, we use it like we use samples. Then, like for example, poem or other, there is no evidence on this. But if I have bleeding, then I use them just to keep myself happy that I'm going to be okay. Probably it's treating ourselves rather than treating the patient. I'm not sure, but I think it can be used and it can be helpful as well in the bleeding. But if bleeding happens, as we all know, it have just to be managed and look into it carefully, like any other endoscopic bleeding. I hope this answered the question because I did not really hear it all together.
I think because of the poor connection, he was not able to
Yeah.
voice his question properly. Khalid, you wanted to say something?
No, I think Iman, this was an excellent talk. Thank you for getting online and giving us an overview. Very nice talk. There are a few points. I think there is a variation in practice based on from center to center, region to region, and it's not only one way is the correct way, and there are multiple ways to do the same thing correctly. One thing is it's interesting that you always do a pancreatic sphincterotomy, and I never do a pancreatic sphincterotomy. I always do just a pancreatic stent. On the other hand, some people don't do a biliary sphincterotomy. For me, if I see a bile clearly flowing through, I may not do a biliary sphincterotomy. But if it is not, because heat causes an edema around that area. So sometimes if you don't see a bile flowing from there, then I would do a biliary sphincterotomy because they can develop a post-ERCP cholangitis. So that's one of the points, maybe a difference in approaching these lesions. Other thing, I have a few points, Yas, by just 2 minutes. I'll go step by step with those points. With regard to EUS, I think if I personally don't do in all of the ampullary lesions, especially if it's less than 1 centimeter, I'm looking at it. To me, it looks resectable, no advanced features. In those cases, I would not do EUS. But one of the advantages of EUS is also in patients with pancreas divisum, because if somebody has a pancreas divisum, you see that on EUS, at least you avoid poking into the pancreas and trying to get into the pancreas, and you won't find it. So that saves a lot of hassle there. That's one thing. Other thing is, if for especially trainees who are early in practices, and you see a patient live with the ampullary adenoma or ampullary lesion, if for any reason they need a biliary decompression, please don't do a sphincterotomy. Just put a biliary stent in there and leave it alone, and send it to the expert to take care of that from there onwards. Dr. Al-Fada already talked about injection. If it is just an ampullary lesion, I personally do not do an injection on that. But there are going to be lesions which are laterally spreading. And usually lateral spread, mostly it happens on the sides or downwards. Sometimes it happens upwards, superior to the papilla, but usually not. It's usually lateral or lower. In those cases, you have to make a decision. Do you do ampullectomy first, or do you resect the laterally spreading part first? So if I don't see anything superior to the ampulla, I may just do an ampullectomy first and then put a PD stent, and then I have time to work on the rest, and I can do an injection on the rest, submucosal injection. So it really depends on the case scenario, whatever is the situation. With regard to snares, I think you very nicely elaborated on those, what type of snare you use. I personally prefer a thin wire snare, because the duodenum itself, one thing is thin, especially for laterally spreading. So I want it to cut quick. For the ampulla, also, I prefer a thin snare. For me, it's an oval Cook snare where the wire diameter is close to 0.37 millimeter as compared to the Boston snare or Olympus snare, which are more than 0.42 millimeter in thickness. So thick the snare wire, more cautery is gonna apply. So more cautery effect on that. And sometimes when there's a good amount of tissue in the snare, it may take 3, 4, 5 beats before it comes through. So don't be worried about that it's gonna cause a perforation. If you are in a good place, you have grabbed it good, it will be fine, it will come through. Other practical tip is right 2 minutes before I'm gonna cut, I give a glucagon. And so either you can use a Buscopan or use a glucagon. That way, as soon as you cut the ampulla, you won't lose it. It would just sit there and you have time to grab it. And these are the main points I wanted to just talk about. And if there are any other questions, I think John is on there too. And I don't know what's his take on sphincterotomy, especially pancreatic and biliary sphincterotomy or stents. One other thing is, there have been, I don't use methylene blue for pancreatic duct orifice. Some people do, and that's absolutely fine. And I don't put a stent first. in the pancreas and then try to cut through. I cut it. I do a pancreatogram first, and especially there, I'm not sure if it's a pancreas divisum or not a divisum. In those cases, I like to do a pancreatogram, and sometimes that's helpful when you do after you are done with the ampullary, then you know the trajectory of your cannulation and axis of your cannulation into the PD. So I'll stop there, and I think we can take John's lead on sphincterotomy, especially pancreatic artery.
Yeah, thank you. First off, Dr. I've had a fantastic talk, excellent show, some brilliant cases. I think the first thing I would say is that the important thing here is you should know what you're doing before you even start. So the workup on this patient, how fit they are, all the things you said about, if you've got an 85-year-old who's got severe heart disease, why are we bothering with an ampullary adenoma? Leave that alone. They're going to die of their heart or lung disease or something first. So case selection is the absolute key to this, because the actual procedure itself, you're snaring off the ampulla. People talk about difficulty cannulating, and generally, what I very much like Hassan. Once you've actually cut off the lesion, normally the orifices are just looking straight at you. It's some of the easiest cannulation you ever do after that. My personal take on this is I do exactly as you've described. I reset the lesion. If it's a lateral spreading lesion, I think there's no hard and fast rule. I remember one that was half the duodenum. We actually took most of the lateral spreading lesion and came to the ampulla last. That was just technically easier in that case. I don't think there's any hard and fast rule. Sometimes it's a big sticky out bit, then you take that bit off first. But for me, once you've done the actual ampullectomy, you need to be getting if you're going to do stents or sphincterotomies, you need to be doing that bit fairly soon afterwards. You don't want to take off the ampulla, then spend an hour taking off the rest of the bit on the duodenum for them to then get pancreatitis because you haven't put in the prophylactic measures. I don't tend to do sphincterotomies on these patients. I put a PD stent in, 5 French single pigtail, so that it will come out, although often they don't. And generally, again, there's no great evidence for this. I've generally put in a biliary stent, not done a sphincterotomy. And my concern, like Hassan said, is that after thermal ablation, after thermal treatment, you get a bit of stenosis, and it's quite easy to then place a stent at the moment. But if they get biliary obstruction later, it's harder to come back and deal with that. Again, I think the thing for trainees, again, case selection and thinking ahead. The big worry in these cases that in the series is up to 20% risk of pancreatitis. This is one of the most high risk pancreatitis procedures you'll do. So use everything you can to try and reduce that. So non-steroidals as long as they're not allergic, PD stent without any doubt whatsoever, intravenous fluids, we're starting to see evidence that that's now of benefit. And the best way to not get pancreatitis is don't do one that doesn't need to do. So do the case that needs it, and pre-op counselling and all that kind of stuff. Personally, again, the other thing that Hassan and Dr. Rafal were saying is absolutely right. The duodenum's got 2 blood supplies, remember, one from the top, one from the bottom. It loves to bleed. It oozes like hell. You take these things off, it looks beautiful to start with. So that resection you showed was great. About a minute later, I'm sure it started to get quite red and murky. They always do. There's something about the duodenum, it just loves to ooze. And so there's some interest in using things like Puristat, which is some of these gels, to try and see whether this might be of benefit. There's no evidence for that yet, but it's a good idea. I think there's a study that's worth doing there. What was the other thing I was thinking? Yeah, don't lose your sample. That's why you've done this in the first place. I've generally done an EUS on the patients if it's big enough, or if there's any question about it. The only reason EUS is useful is for intraductal extension. If it goes more than a centimetre up the duct, you're going to struggle with that endoscopically. There's some people I've seen in the past talked about going into the ducts with snares and trying to pull bits out. Personally, I think that's quite sporting, I think is the word to choose for that. So I think if it's all on the, it doesn't matter how big it is on the surface, it will come off. It's how far up the duct it's gone. If it's gone a long way up the duct, you're into surgical territory, or creating acute surgical territory, which is not much fun either. So and again, in my centre, out of the 3 of us who do the advanced endoscopy, it's only me who does these, because there are not that many cases. You need to what's the word? You have someone who's doing a lot of it, so they get good at it. They're not an emergency. There's something you can spend time getting it right before you start. And I think that for me, as Dr. Alfada and Hassan have said, absolutely bang on the money. You need to be knowing what you're doing. before you start and have everything ready. And funny things happen. There was a great case on one of the live meetings many years ago now that Mike Burke, one of the most experienced guys for doing this in the world did. I think he was in the Asian Institute, took this thing off and 2 huge arterial bleeds started immediately. And he actually very well showed how to sort that out. But, it looks straightforward. You cut it off. These things are vascular. They want to bleed. You just have to be ready for clips, coag graspers, whatever you need to get these things under control. Have it all drawn up and ready. Don't be saying, oh, where's the clips? And someone has to go to another room to find a clip. Patient's bleeding. You need to be ready for this stuff in advance. And again, thank you very much for a fabulous talk this afternoon.
John Khalid Al-Fada, if you see that there's an invasion of CVD by the abnormal tissue, will you proceed with the ampullary? You've already said that you'll be careful. John, you've already said that you'll be careful. But in context of the first question that was given, what are the clear-cut signs that you'll say, no, I'm not going to proceed based on these US and ERCP images?
Yeah, this is for me the important question. I think all these cases you've been having a lot of discussion about it. What is the exact length of the lesion that you have to go? Do you have really to handle and not to do anything if you have any extension or no? Is this extension, what is the tendency of this extension to be malignant? But well, if you have a lesion there, then you have to resect it. Then if you do it endoscopically, you might lift something over. Maybe doing a sphincterotomy, as was mentioned by Dr. Leeds and Dr. Hassan about this. Maybe later you can go and probably ablate a part of the common bile duct distally that was there. But to be honest, if the patient is young and if he's having a clear extension into the biliary or the pancreatic duct system, I rather send those patients for surgery and not really to do a endoscopic intervention in those patients. Looking into the risk benefit of the lesion itself is important actually, and I'll be happy to ask to hear from Dr. Muhammad and Dr. Leeds about it. And when we do these things by clinical practice more. We are not very much good in reading, but when I went through this literature now, and I found that this topic really is not that much looked into it by evidence. And that's why I'm happy hearing that everybody's having his approach. I have a friend of mine who's doing as well this procedure in a neighborby hospital, and he never do a sphincterotomy, and he sometimes places a PD stent before, so it helps me to guide, and if I want to retrieve it, I can just retrieve it. So it's a nice thing that we really don't know much, but I think we want to know that what is the best evidence on this, and I hope something will happen. Now, if you look into the literature that I looked into, there is no clear data or consensus on anything that have been mentioned, probably because there is no good evidence into this, and even the expert opinions varies. So I'll happy to hear from Dr. Muhammad and John, please.
I think this is really interesting.
Yes.
Yeah.
Yes.
Sorry.
Ah, did it? Well, one of the things I wonder about is whether actually we should just get all of our data together. That'd be quite an interesting idea, and see what there is. And I think you're right. Unlike colonic polyps, for which there's oodles of data and lots of randomized trials and what have you. There's lots of questions to be asked in this area. One of the areas that would be very interesting, particularly those with a bit of introductory extension, is whether things like endobiliary RFA might be a useful way of ablating that distal bit of lesion, whether it's benign or malignant. But again, I want to hasten to say there's no great evidence that that's a thing to do, but technically it would be very, very doable. Yeah, thanks, gentlemen. Just said we should pull our publish our data. Well, that's a very attractive thought, I have to say.
Yeah, I think there's really not a very much randomized or prospective data on that. Everything you look at it, literature, it's mostly retrospective, be it EUS, be it anything on that. So that's why there is so much variation in practices of this. And with regard to these adenomas or these ampullary lesions with extension into the bile duct, there are some retrospective data that even up to 1 centimeter, it's okay as long as it's a benign lesion. You can resect that. You can resect inside the bile duct as well. But I completely agree with Dr. Alfada that it really, really depends on multiple patient factors, especially if it's a young patient with the extension into the bile duct. I would send that to surgery. And I would ask surgical opinion. If it's a 80-year-old and had a 1 centimeter ampullary adenoma, I may not even want to do anything to them, especially if they are not obstructed or they have no, they were incidentally found to have those. So it's such a variation. Yes, you can ablate this extension into the bile duct, but we really don't know how much we are benefiting these patients. They may not have a problem and we give them a problem to deal with. So it's really depends on the case scenario, depends on the patients. And in these type of cases, really, it's a multidisciplinary approach. And at the end of the day, for an elderly patient with multiple comorbidities and no evidence of cancer and no evidence of obstruction, maybe it's better to leave them alone. That may be a favor, that you may be favoring them by leaving them alone.
Yeah, you make a really good point there. Sometimes we get sent these patients, don't we, because the surgeons don't want to operate and they think we can just do an endoscopy. Well, of course we can, but the risk of this is really quite high. So if we leave them with pancreatitis or perforate them, one of the big problems is that then they're not operable. So you've really just offered the patient no benefit whatsoever. I think that's a really key point that you've both made. That you've got to think of what's the risk of this actually turning to cancer and causing a serious problem for this patient over the next 5 years, and is that higher or lower than the risk of doing an ampulectomy? That's the key move on this every time.
Do you want to say something?
Yeah, if you can hear me now. Can you hear me? Sorry, I was in the middle of a procedure. Just a couple of points. I mean, I think while it becomes very clear that there is really no agreement and one should, until such time, one should continue doing what you think you're good at. Having said that, I think, you know, those who've been doing it, I'm sure most of us have been, pancreatic duct becomes difficult to cannulate. So for those who actually put a pancreatic duct stent because they see the duct initially and then do an appelectomy, especially if you're not so experienced as the other experts here, then I think it's not a bad choice to do that, because once the lesion starts bleeding, it becomes even more difficult. The other thing that's very important in our part of the world where we have limited resources is before you embark on something like this, you have to ensure that you have all the modalities that you may need in case something goes wrong. Because there's no point going in for something and you have, you know, 2 nice vessels spurting at you and you're short of something, whether it's clips or whatever you use for securing that. I think it's very important to understand that and to have the knowledge before embarking upon this, especially with last point made, where you may actually make things worse for your patient. You may not be actually benefiting. So it sounds very good, and it makes you feel good that you can do an ampulectomy. But I think we also need to ask how many ampulectomies that we have done have actually benefited our patients really, and what would have happened had we not done them. Those are the points I just wanted to make. Thank you very much. Excellent talk and discussion.
But sir, at the same time, we must remember that majority of the patients that we deal with, the patients are younger than 60 years of age with ampullary adenoma, and we have to be very careful in terms of possibility. At least 1/3 of the patients, they have ampullary carcinoma, along with when we deal with these patients and doing ampulectomy in these patients and doing incomplete resection and sending them away with a false hope that we have cured the disease. And the patients may come back with the recurrence. And in that context, I have a very important question which has been uploaded to me. Do you see at the lymph nodes in the vicinity of the pancreas or in the vicinity of the duodenum when you go ahead with the ampulectomy? Do you give any importance to the presence of lymph node, the size, the shape?
So that's interesting. That's interesting. If you do a US and you see a lymph nodes, and that would concern me actually. And Especially in those cases, I would be concerned, like either I'm not looking, I'm not getting a whole picture of the lesion. Seeing ampullary adenoma itself should not be causing periampullary lymph nodes or peripancreatic lymphadenopathy. When I see those, if I see those, I would be concerned. I would do a further investigation before embarking on those with the ampullectomy or something else. I don't know what John would, what do you think, or Dr. Alfada, what do you think?
Yeah, I totally agree. I mean, as Dr. Khalid said, it's a global kind of assessment. So you cannot just look into the lesion, getting interested to resect it, while you have a 1 or 2 centimeters above it, and then you have those benign slash malignant 3, 4 lymph nodes. You don't know if they are metastases or no. So I think finding other modalities, not sure what you have to do exactly at that time, but probably FMBing those lymph nodes and making sure that they are not hindering any kind of malignancy. Maybe asking to the hepatobiliary surgeon not to do a total, not to do a hepatogenostomy or whatever, just to do an excisional lymph node biopsy, probably of this area, looking if there is any area of metastasis or any area of involvement. That's a very excellent question. And I don't think there is a black and white on this, but it's important, I guess, to look into the lymph node situation around. And that might be one of the good reasons really to look into the EOS rather than doing an MRCP and CT scan, which might not be as good really as EOS and a preampullary region.
John,
Yes.
you want to say something?
Yeah, I think for us, we would, like I said before, these aren't an emergency. They don't present as someone who usually needs something doing immediately. There's time to get all the information you need. And for me, we tend to put these through our HPV NDT or tumour board, whichever you would do, which involves the surgeon. So should the cross-sectional imaging or an EUS show that there's a lymph node, like Hassan and Dr. Alfada said, I'd be thinking, not so sure like that. They can be reactive, please don't be wrong. You know, I think the presence of a lymph node doesn't necessarily mean it's unresectable endoscopically, but it starts to push it in the other direction. And an NDT means you actually think about things in the holistic sense. It's very easy to see a polyp and think, yes, I can remove that. Like we've all said, is that the right thing for the patient? Is that the best thing for the patient if they're young and otherwise fit? Then, you know, I mean, the thing is you are committing someone to a Whipples, and that's life-changing surgery. So you do have to just bear that in mind that, you know, if someone is going to live for a long time afterwards, these surgeries do have their own morbidities and issues as well. So, you know, be clear. I've certainly removed some very early cancers for some of our slightly more elderly patients. When it's clearly when it's been more of a stalked thing that's kind of hanging off into the duodenum, you can get a good margin if you're careful with that. But the other thing I was going to say about which Dr. Alfada mentioned was about the things that you would go against trying to reset. If it's ulcerated, if it's fixed, if it won't pick up in the snare, there's that feel to the lesion. You know, you can find yourself very easily just hacking through into the retroperitoneum, and you really don't want to be doing that.
Yeah, it's a fixed, ulcerated, indurated, smooth. All these are bad signs. You want to stay away from that. So no question about that. Other thing with regard to bleeding, it's just anecdotal, my own way of doing it. If it's a larger either duodenal adenoma or laterally spreading these ampullary lesions, after resection, I spray a Carafate on those. It's my personal only. And I have noticed a little bit different, especially with this oozing. That helps a lot. And a lot of these laterally spreading tumors, they're gonna ooze. And so it's in my experience, for me, it works in preventing that oozing.
Nadeem, do you want to say something? Nadeem, are you there?
Yeah.
I think connection is not good. Nadeem, we can't hear you properly.
John, I thought there was going to be internet problem in England at least. We can.
Well, I had a problem. I had to
Fantastic.
switch over to my in-laws' place.
It's really variable. He's in south. I'm in the north. He's in the south.
And Nadeem, we can't hear you at all.
Nadeem, we cannot hear you.
I think I've said most of my points in the chat section, and I think I probably won't take much of your time. Fantastic call. Thank you.
I think we've lost him. I think we're done with the most of the questions and queries which have been put forward. It remains for me to thank Dr. Abdurrahman Al-Fada. He is a brilliant presenter. I keep seeing his cases at the Middle East Endoscopy Forum and similarly at other forums. He is an emerging star. Rather, he has already emerged in the endoscopy in the Middle East. So he's getting more and more recognition for his endoscopic skills. I'm really thankful on behalf of Pakistan Society of Gastroenterology and College of Physician Surgeons for sparing your time. At the same time, thankful to Khalid, John, Nadeem, Saad Niaz, and all the other participants who have spared the time to join this session. At the same time, thankful for Dr. Saeed and Wilson Pharmaceutical for providing us the platform for organizing this webinar. So see you next week. Take care. Allah Hafiz. Bye-bye.
Allah Hafiz.